Good morning, everyone, and welcome to the Healthy Aging Core webinar, Closing the Gaps, Advancing Emergency Preparedness, Response and Recovery for Older Adults, what community-based services and programs can do. My name is Barbara McMillan, and I am Provincial Community Engagement Coordinator for United Way of BC's Population Health Team, and I'm very pleased to introduce this very important and timely event. I'd like to begin by recognizing that I'm speaking today from the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And as this is a pan-Canadian webinar with participants from all over the country, we also acknowledge the traditional, ancestral, and unceded territories of all First Nations on which we gratefully live, work, and gather. To manage the session and ensure good audio and visual quality, there's a few details we need to point out. Everyone but the presenters will remain muted and cameras will be off. Feel free to introduce yourself and where you are joining from in the chat box. A number of you already have done that. There's also a Q&A box where you can post your questions. And at the end of the presentations, we'll have about 10 minutes for Q&A and discussions. And please direct who you would like your question answered by. The webinar is being recorded and will be posted on Healthy Aging Core along with the slides in the next day or two. And also following the webinar, all participants will be sent a brief survey to provide feedback and ideas for future webinars. And so we encourage you to look for that and let us know what you think of the session. And beyond the webinar survey, please feel free to follow up with us and share a story of emergency preparedness, response, and recovery in your community and what your organization's experience has been, as we expect that today's session is just the beginning of a longer and deeper conversation on this topic. Because while natural and human-caused disasters and emergencies have always tended to affect older adults more severely, the pandemic of the last year and a half and the heat waves, forest fires, floods, tornadoes, and other severe storms of the past several years and recent months have provided too many tragic examples and statistics. But these events have also provided many positive stories of community-based organizations, staff, and volunteers, as well as individuals in community of all ages, responding quickly, effectively, and compassionately, such as 8-year-old Jackson, who told us he wants to donate his allowance to people who have lost their homes in the fires. The fact is, we can all do something, both personally and professionally, to close the gaps that exist when it comes to emergency preparedness, response, and recovery, particularly for older adults. When we first launched CORE BC, or Collaborative Online Resources and Education, the Healthy Aging Knowledge Hub that was the model for CORE Canada, I found very few studies or resources on emergency preparedness and response that were specific to older adults. So I was really excited late last year when I saw the Canadian Red Cross and the National Institute on Aging had released a report titled Closing the Gap, which identifies 29 evidence and expert-informed recommendations aimed at improving emergency preparedness, response, and recovery for older adults across Canada. These recommendations are intended for governments, organizations, and individuals to improve emergency preparedness, response, and recovery for older adults, and to provide interventions to bridge existing gaps in emergency preparedness, response, and recovery. I think I need a short form or an acronym for that phrase, ultimately contributing to better outcomes for older adults across the country. So I'm very pleased to introduce the lead author of the report, Dr. Samir Sinha, who is Director of Geriatrics at Sinai Health System and the University Health Network in Toronto, and a Professor of Medicine at the University of Toronto, and the Director of Health Policy Research at Ryerson University's National Institute on Aging. Dr. Sinha is a highly regarded clinician and international expert in the care of older adults. Some of you may recognize him from many interviews on the news over the period of the pandemic. A Rhodes Scholar, architect of the Government of Ontario's Senior Strategy, and in 2014 named by Maclean's Magazine as one of Canada's 50 most influential people and its most compelling voice for the elderly, and more recently appointed to serve as a member of the Government of Canada's National Seniors Council, as well as leading the development of new national long-term care standards for Canada. And beyond Canada, Dr. Sinha is a fellow of the American Geriatrics Society and a member of the American Red Cross Scientific Advisory Council, and has consulted and advised hospitals and health authorities in many countries throughout the world. Following Dr. Sinha's presentation, we'll hear from 3 people who will provide examples of on-the-ground preparation, response, and recovery in several communities. Kristi Rintoul has been with United Way for 5 years and as Community Impact Manager, supports impact and investment work throughout the interior of BC. Kristi has degrees in both child and youth care and communications and over 15 years experience working in the not-for-profit sector. Her journey so far has included scraping together programs for grassroots charities on shoestring budget. I think many of us know what that's like. Providing outreach to marginalized youth in some of Canada's poorest neighborhoods, advocating on behalf of the not-for-profit sector, and supporting an investment of millions of dollars in operational and program funding. More recently, as the wildfires in BC have become more and more prevalent, Kristi has found herself involved in response and recovery work and speaks to the essential service the nonprofit sector provides in supporting our vulnerable community and members during crisis. Michelle Hawkins is the Executive Director of the Logan Lake Wellness Health and Youth Society, an organization that focuses on community wellness, offering programs such as Better at Home, literacy, active aging, creative kids, Little Learners Preschool, and many more. Michelle has lived in Logan Lake since 2004 and has been engaged in her community, previously as a volunteer board member and chair, and now as Executive Director of the Logan Lake Wellness Health and Youth Society. Currently, she volunteers as Vice Chair for the board of the Logan Lake Daycare Society, Chair of the board of the Community Futures Sun Country office, and in her role as Executive Director of the Logan Lake Wellness Health and Youth Society, she chairs the Logan Lake Community Wellness Action Group table. Some of you might be looking up Logan Lake on your map, but I'm sure many of you have seen Logan Lake in the news this past summer, given the fire hazard there. And our third respondent is Aman Fazal, who is not only running the tech end of this webinar, but also presenting. As a community volunteer for over 25 years, Aman has worked in various capacities to serve the needs of community members of all ages. Service to others is an important part of his life, and after spending the beginning of his career in digital marketing and public relations on both the agency and brand side, he shifted into the nonprofit sector, and we're very happy to have him working with us here at United Way, British Columbia. With aging parents, aunts, uncles, and close loved ones, Aman has become more aware of some of the challenges our aging population faces. In addition to his work at United Way BC, Aman serves on the board of directors for British Columbia's Original Minds Association and is a member on the Aga Khan Council for British Columbia and its activities with that latter organization that he's going to share today. So over to you, Dr. Sinha.
Thank you very much, Barbara. I'm just going to share my screen and bring up the presentation that I have prepared. So just bear with me for one moment. And what I'm going to do is go to presentation. And there we go. I think we're good to go. And I will look for a thumbs up from Barbara. I think so. Perfect. Okay, so as Barbara was just mentioning, some of the work that I'm going to present on is related to work that I did in partnership with first the American Red Cross, where I'm a member of its Scientific Advisory Council, and then in partnership with the Canadian Red Cross, who want to look at these issues specifically within the Canadian context, and really thinking about advancing emergency preparedness, response, and recovery for older adults in Canada. So I just want to present, I want to have three objectives today. One is to understand how and why older adults are disproportionately negatively affected by natural disasters, epidemics, and pandemics. Then we're going to identify some of the key domains around which to consider emergency and disaster preparedness response for older adults. And finally, we're going to describe some of the key strategies we can promote to better support older adults to prepare and respond to disasters and emergencies. So just to set the context, I think folks, especially in BC, but across Canada, have certainly been experiencing a variety of emergencies and that are related to climate, but also other things as well, like our ongoing and never-ending pandemic. And what we do know is that older adults experience more casualties after a natural disaster or an epidemic compared to other age groups experiencing similar events. This is time and time again always seen to be the common result. And if we set the context as well, I mean, many people know of Hurricane Katrina, one of these iconic events in the last 20 years, and how significantly it affected the lives of many Americans living in the coastal mid-Atlantic. But one thing that most people don't know is that 49%, almost half of the lives taken, were persons who were 75 years or older. And many of the victims sadly died in their homes, while persons were found in nursing homes were abandoned or assumed to be abandoned by caregivers. And more recently, when we saw what happened in New Orleans and Louisiana, we saw again some of these similar issues were once again playing out, with people being abandoned in their nursing homes and other situations as well. When we looked more recently in 2010 at the heat waves that were happening in Quebec at that time, again, we found that more than half of all deaths resulting from that heat wave were amongst persons 75 years of age and older. And again, in 2017, we found that older adults were the population hit hardest by springtime floods in Quebec. And unfortunately, it was found that there was poorly coordinated protocols that left many but more vulnerable due to delays in initiating evacuation procedures. I know we can talk about other things like the Calgary floods or the BC forest fires, but these were just some of the references where we actually had collected and reported that data publicly that we could share. But again, many, many examples where older adults are disproportionately being affected. As it relates to COVID-19, for example, what we do know is that, again, not only are older adults disproportionately affected, and this is data from 12 countries around the world that my colleagues and I produced last summer related to the first wave of the pandemic, but what you will see is that Canada was a particular outlier across 12 countries that we compared. Canada, what you'll find, is to the far right of your screens. And you can see that if you were a person, the green bars represent people who were under the age of 65. And really, if you were a person who was under the age of 65, we knew that just by being an older community dwelling older adult, you had a much greater chance of getting sick and dying from COVID-19. And especially, it was almost 1,000-fold for those people in the red bars who represented older adults who were living in our long-term care retirement homes. And in fact, we saw a 74% or 74-fold greater chance of dying if you were an older person in Canada living in a long-term care home versus being a community dwelling older adult. But again, almost a 20-fold greater chance of being affected if you were living, if you're an older person living in the community versus a younger person living in the community. So significantly disproportionate effects on older populations, not just in Canada, but around the world, but particularly in Canada as well. So we know that right now, persistent poor outcomes highlight the persistent gaps in disaster preparedness planning and procedures for older adults. And why does this actually matter? Well, we know that in 2014, older adults at that time made up 15.6% of Canada's population. Currently, this population represents 18% of Canada's population. And we know that by 2030, they're projected to make up about a quarter of our population and 28% by 2061. We know that there will be an increased demand for emergency response services provided by healthcare professionals and emergency responders. There will also be an increased need for age-friendly and sensitive procedures and processes at the organizational and government level. And we know that there's expected to be a continual increase in the severity and frequency of natural disasters. And there's significant financial burdens where we've actually had cost estimates done related to hurricanes alone. You can see these costs are not minimal. These are huge costs, easily within the tens to even the hundreds of billions of dollars. So what makes older adults particularly vulnerable in the context of disasters and emergencies? Well, we first of all did our work by conducting and just an overall literature scan to understand what does make older adults more particularly vulnerable. And we found that there were 7 domains in particular that we identified. One is that we know older adults are more likely to be living with chronic health conditions. And we also know that older adults are more likely to be experiencing physical impairments that might limit a person's physical capacity to coordinate actions or perform physical activities. We know that older adults are more likely to be living with sensory impairments. This could impact their vision. This could impact their hearing, for example, and this could be these are important sensory modalities you need when responding to a disaster emergency. Cognitive impairments are more common in older adults as well. And again, cognition is important to be able to navigate challenging situations. We also know that there are psychological and social factors that need to be concerned as well, that really can actually impact someone's health and safety, as well as issues related to accessibility, equity, and social determinants. Again, if you're poor, if you don't have access to the right resources, for example, then it makes it very much harder for you to be able to respond in a disaster emergency. And this also relates to the concerns around finances and family caregiver considerations. Again, if you don't have the right resources and supports, it can make it harder to respond to an emergency, especially as an older person. So we took these concepts as well, if you will, around the outer ring of the circle here. And then we also looked at other domains, for example, that really where one needs to think about how these things need to be considered. And this is really at the idea of the government and policy level, at the community programs and agencies level, at an organizational level, at a healthcare professional level, and also, most importantly, at the level of older adults and their caregivers as well. And so by using this framework for analysis, we were able to then really frame a question that we wanted to answer. And really, when we do a scientific review through the American Red Cross Scientific Advisory Council, we have to come up with a research question that bases our work. And really what we did was we asked the question, what evidence exists for older adults 65 and older in any jurisdiction of any intervention or action for them and or by them compared to adults under 65 to prevent, respond, and or recover from a natural man-made disaster or infectious disease epidemic or pandemic, and so on. So this is what we call the Pico Framework, in which we phrase a scientific question. And then this was really the review that we then ended up doing. So we used our question. We then did a detailed literature review using a number of different databases, and we looked at a whole bunch of different kind of natural disasters, but also infectious disease kind of pandemics. And in total, we identified 4,390 articles, as well as 15 legislative and policy-oriented documents. And in the end, we used 86 of these documents for our data extraction. Whenever we read a document or a scientific paper, for example, we often want to look at the quality of the evidence, and we do what we call grading to say, is this high quality evidence? Is it moderate quality? Is it low, or is it very low? And you can do this often with quantitative analyses, but often a lot of the literature we were looking at was qualitative in nature, meaning that it was not necessarily based on data, but reporting on experiences. And so again, we wanted to look at these measures so that we could actually look at the quality of the data we were looking in that could help us to come up with recommendations. And so we also then hosted a policy roundtable. And really the reason why we hosted a policy roundtable was that because the scientific review uncovered the need for recommendations surrounding guidance for individuals and unpaid caregivers, community-based services and programs, healthcare professionals and emergency response personnel, care institutions and organizations, policy and legislation and research domains. And so in partnership with the Canadian Red Cross, we hosted a policy roundtable to bring together experts from across Canada in May of 2019. And really, ultimately, the end, in terms of with our group looking over the data, we were able to come up with 29 evidence-based recommendations to inform the development of the Canadian Red Cross National Institute on Aging policy paper. And really, we came up with 9 recommendations specific to older adults and caregivers, 4 around community-based services and programs, 3 relate to healthcare professionals and emergency response personnel, 3 relate to care institutions and organizations, 5 around research, and 5 around policy and legislative reform recommendations, all relevant to the Canadian context as well. I'm not going to go through each of those recommendations, but certainly, as Barbara mentioned, you can certainly read the policy paper. It is available online through the National Institute on Aging website, and you can go through and look at all the recommendations and also the evidence and the rationale behind each of the recommendations that were actually made. So this was published in December of 2020. And really also incorporated data and new evidence that was coming in relationship to the COVID-19 pandemic. So really, what does this translate to? It's great that we came up with, policy recommendations, if you will, but what does this actually matter, if you will, to frontline providers or people organizing or creating programs? Well, I want to kind of summarize kind of the core findings into two kind of batches of thoughts and recommendations, if you will. Number one is, when we think about older adults and caregivers, it's important to raise the topic of disaster and emergency preparedness with older adults and their caregivers, because often we don't often raise this enough as an issue. And it's almost that we tend to find people who are stuck in situations where they never considered they'd be in them, and then didn't have enough time to prepare or organize themselves in advance. So really, this is some of the thoughts that we said. These are things we can do, is we can think about advanced care planning. And really, when we think about advanced care planning, people say, well, if I have this health condition or I have that health condition, this is what I would want. Well, part of advanced care planning should also incorporate disaster and emergency preparedness. What would I need? What would I do if this happened, if there was a forest fire, if there was a flood? So understanding what are some of the natural disasters or things that could happen, and how would I try and be prepared for that situation? We want to make sure that people can recognize an older person's preferences, capabilities, and limitations, both physical and cognitive, and how to prepare with these in mind. So if one knows that they have a person, for example, who has physical limitations, where is the adaptive equipment? How are we going to easily transport that adaptive equipment, like a walker or wheelchair, if one has to evacuate? Is it better to have a second set that's actually in the trunk of a car, for example? If someone needs to evacuate, for example, and they're living on their own, do they have someone that they can count on to help them navigate an emergency, because they might live on their own and they might need the help of a caregiver, for example, or a friend who could help them out? So it's often thinking about, if there's also issues with dementia, for example, what is our plan so that we're not scrambling around that, but we can better support that person who might have cognitive issues to better be supported. What are the types of disasters that could occur? So I mentioned that a little bit earlier. It's about saying, if you live in BC, you might want to think about, okay, forest fires are more of a reality there than, say, in downtown Toronto. I know that in Toronto, we have a big nuclear power station not too far away. So these are things that I'm like, oh, that could occur. And so I made sure I got my iodine tablets, for example. So think about the things that might actually occur, and how one could anticipate them happening. Everything from power outages to pandemics, and what one might want to do to think about preparing in advance. One thing that really came up a lot in our deliberations was, if an older person is on a power dependent equipment, do they have a backup power source? So many of you may have heard recently about the hurricane and the storms that hit New Orleans, and how much of the power grid and much of the state was out for almost a week on end. So now imagine a person's on a ventilator or other medically important equipment in their own homes, and now they didn't have another power source to use while it took time to restore energy. What would they do? So have we thought about that? Another aspect is, in some jurisdictions, there are what we call vulnerable persons registries that people can place themselves on. And that way, if people are organizing mass evacuations or doing sweeping a neighborhood after an episode, sometimes these registries can be very helpful, so that emergency response personnel can better organize themselves to go to people first who should be prioritized to be supported. We also say to encourage, patients or clients really to make friends that they can rely on. So sometimes if a person now says that I'm living on my own, I don't have anybody I know, this is where we encourage people to get to know that neighbor, get to know a friend at church or at mosque or whatever, so that you actually do have a support network that you can rely on and that they can rely on as well. So these sorts of things can be helpful as you think about what is your emergency response plan. Because having relatives across the country might be one strategy, but having relatives closer at hand is really important. And we also talk about the importance of having lists, supplies like a 30-day advance medication supply, and materials ready to stay or go, for example. So again, little things that we often don't think about, but again, once you start actually teasing it out, these can be things that are important to consider, because again, as we know, disasters and emergencies can strike at any time. So things we can also do when we think about organizations, for example, so care organizations or others, like organizations like the United Way, could your colleagues, for example, benefit from additional training in the care and support of older adults, for example. So again, if you're working in a community that often has older clients, for example, your organization with working with older clients, is there additional training that might be particularly helpful to be able to better respond and support their needs? Do organizations you work with or for have a clear disaster or emergency preparedness plan or procedures? So for example, one of the things we talked about is, services like Meals on Wheels, for example, a really important community service, for example, but how does it pivot, for example, if there is a pandemic? How does it pivot, for example, if there is a local power outage or other things? That service might be required to ramp up and support more people than it usually does, or how does it keep operating when many people are dependent on it for food? So what are those sorts of things that one can look at how to better support? Sometimes these might be the right services that can help identify people at particular risk, for local emergency response personnel. And in this respect, are local governments or agencies able to easily leverage data sources to identify at-risk individuals? Just what I was speaking about. When we think about shelters, again, if your organizations are at all involved in providing or creating local shelters, are they able to accommodate people with different physical and cognitive abilities? Often a lot of shelters are built, but they're not necessarily built with accessibility in mind, and thinking about the particular needs that older adults might have. And do we also have, are we also thinking about the importance of good, high quality information handoffs, especially during what we call patient transfers in times of disasters or emergencies? Often we find that people with chronic health conditions are particularly at risk because they can't get their medications renewed. They might have forgotten which medications they're on, or not have, or their pharmacy might have been affected. And so when we're handing off individuals between other individuals, if we documented or carefully collected important information like medications, health conditions, other things people need to be aware of, how are we making sure that that key information is appropriately transferred? So again, this just gives some of the examples of what organizations can think about, but there are a few more that we mentioned in our policy paper. So I'll stop there, and I'm going to hand it over to Kristi now. And if you do have any questions at this point, we are, again, as Barb mentioned, we are taking questions towards the end. So feel free to put your questions in the Q&A box if anything has arisen so far. And I'm sure as Kristi and Michelle speak as well, you may also have some questions that you can also add there for all of us to discuss at the end. So I'm going to stop sharing my screen, and I'm going to pass all this back to Kristi.
That was a ton of information. Thank you so much, Dr. Sinha. So as Barb alluded to at the beginning of the webinar, my name is Kristi Rintoul, and before I get started, I want to acknowledge that I'm joining you all today on the ancestral and unceded territory of Tecumseh here in the interior of British Columbia. I'm going to spend the next 5 minutes only of your time just giving you a real bird's eye view of how United Way, Thompson Nicola Caribou responded to the BC wildfires, both in 2017, 2018, and most recently this past summer. So following a disaster, United Way is there to help. We're involved in local disaster recovery in a variety of ways, from coordinating community response to ensuring the most vulnerable have the help they need. In collaboration with a network of community partners and government agencies, we are poised to act quickly when disaster does strike and continue to work in the long term, investing in mental health and wellness support to build resilience in affected communities. As an example of some community-driven sort of collaboration, after the smoke cleared from the 2017 wildfires in BC, United Way, in partnership with Red Cross, brought together a team of 6 community wellness managers. These wellness managers were located in 4 of the most affected regions to support community recovery, resiliency, and wellness in the wake of the natural disaster. Through the coordination of 4 mental health working groups, the community wellness team executed the actions that came as a result of a cross-agency collaboration and action planning. The team also ensured that mental health and wellness resources were available to all those in the immediate and surrounding rural communities. Gaps in services were noted and filled as resources would allow. And knowing that recovery takes years, not months, the positions were in place for 2 years and the contracts closed at the end of 2019. In addition to collaborating in community, we also knew that training and empowering through education was an important part of resilience. So working in partnership with Emergency Management British Columbia and Disaster Psychosocial Services, we brought 1-day psychological first aid training to community members and agencies throughout all regions affected. Psychological first aid is a program that teaches everyone how to help others experiencing loss, grief, and stress, and perhaps is most important in self-care, particularly in light of pending business closures and curtailments locally after a natural disaster. People learn coping strategies to prevent, identify, and deal with stressful events and help others understand what supports are available and how they can access or help others to access those specialized supports. We also learned after the 2017 fires that suicide and mental health concerns went up. So to understand how one's beliefs and attitudes can affect suicide interventions, we really pushed out the ASSIST training in those communities, which is the Applied Suicide Intervention Skills training. In addition to that, we also saw that many families with special needs, relatives, emergency medical personnel, paramedics, and other first responders requested training that equipped workers and family members with proven strategies for safely diffusing anxious, hostile, or violent behavior at the earliest possible stage before it escalated into violent confrontation through the nonviolent crisis intervention training. And finally, the critical incident stress management training also was noted that it would be very helpful following the wildfires. And there was a number of people throughout the regions that received the CISM level 1 and level 2 training to meet capacity, especially for identified vulnerable populations, including seniors. And finally, we also noted the importance of empowering folks living in their homes to stay in their homes and feel safe in their homes in those rural communities. So through a job creation partnership with the Ministry of Social Development and Poverty Reduction, United Way supported 4 teams throughout, again, the entire interior of British Columbia, fire smarting homes of seniors and vulnerable persons throughout the region. It was a 2-way street in that we were able to provide that fire smarting in these homes, but it was also increased the capacity of EI eligible individuals through providing fire mitigation training. And this was a contract that also lasted 2 years. So that brings us to this past fire season. So we know that this past year was one of the most catastrophic fire seasons in local history and affected tens of thousands of individuals, including the loss of whole communities in the interior of British Columbia. So our appeal is still open, United for BC Wildfire Recovery. And so far we've allocated over $300,000 to local community agencies supporting 4,937 individuals, with 80% of those individuals reported to service seniors. We've met immediate needs through identifying food, basic need essentials, gas cards, and childcare as being paramount in the wake of the disaster, but are now focusing more on recovery. So we know as well the importance of keeping up with folks over the next months to years around their mental health, providing resources, and making sure that we're doing check-ins with folks in those rural and remote communities. So we know that a lot of the dollars that we're raising over the next couple of months will go into supporting agencies that really do that work, and making sure that folks are okay as they come to terms with the loss of their communities, their homes, and the triggers that may come as next year's fire season inevitably descends upon us. So for more information on that, you can look at our uwbc.ca wildfire webpage. And of course, as Dr. Sinha alluded to, I will be available for any questions as well in the chat. So with that, I would like to pass it along to one of our community partners, an incredibly strong individual who's done so much for Logan Lake and surrounding areas. I'll let Michelle tell you about this summer and how they survived it. But I do have to say, the last time I saw Michelle in person was at the Welcome Home barbecue, where they had a cake the size of a table that said, "We won." So with that, I'll pass it to you, Michelle.
Thank you, Kristi and Dr. Sinha. While there are a number of different perspectives to managing wildfire within Logan Lake this year, I'm going to chat with you a little bit about how our organization prepared for it and helped get through it. So on August 12th at 3:30, the order to evacuate Logan Lake, BC due to a wildfire threat was announced. We were confident that we were prepared and our community had a plan in place. It wasn't until 7 p.m. that night when the bus left the fire hall with the last residents that we knew we were correct. In the end, out of a town with approximately 2,400 residents, we had 4 residents that needed a ride out. 4, of which 2 were seniors. This proved that our strategy of collaboration and education was a success. Leading up to the evacuation, the Logan Lake Wellness, Health and Youth Society took an active role in collaborating with other community service providers, our municipality, and emergency service personnel. This meant communication. Our organization joined the Senior Center. Our staff of 4 consists of an ESS volunteer, Highland Valley Outdoor Association members, a volunteer fireman's wife, Community Futures Board Chair, Girl Guide Leader, Literacy, Better at Home, and Community Response Network coordinators, along with a dozen or so core volunteers that are members of the many service groups in our little town. We collaborated with the fire department in promoting fire smart and emergency preparedness, with the community forest in hiring youth to help with fire smart mitigation, with the RCMP in promoting safety, with the community paramedic in promoting education and wellness, and with the Logan Lake EOC to be sure we were a resource for them. On July 3rd, we knew that the Tremont Creek fire was in our region. We had already compiled a list of over 200 seniors within our community that were a part of our Better at Home and Delightful Delivery programs. Several volunteers and staff phoned our list to check in. We asked how they were doing. Were they aware of the fires close by? How were they keeping informed? Did they have a plan, a bag packed, and transportation if they needed it? From these calls, we knew where we needed to focus our attention, and that was making sure that everyone was accessing the communications and had a plan. We were able to get materials from our emergency program coordinator and advise the community to pick up their booklets or access them on our website. Logan Lake was later issued an evacuation alert on July 30th. We sprang into action by sharing the message with our community. Our volunteers phoned each and every senior on our list to make sure they knew about the alert, knew where to find updated information, how to stay informed, secure transportation, and make a plan. From these calls, we had a really good idea of who we needed to keep an eye out for if there was an evacuation. On evacuation day, We made our way to the fire hall, which was the emergency center, and we contacted the seniors we were concerned would need assistance. We worked with the EOC, who secured a bus donated by Tech for those that did not have transportation. Following the evacuation, our staff were dispersed into various communities, but we worked together to make sure our residents were informed. We visited ESS, Red Cross, and evacuation centers, along with many campgrounds to check in on them. When the order was lifted, we knew that our community needed to be together. We coordinated a COVID-friendly welcome home barbecue with the municipality to allow residents to see each other and share their experience. Along the way, we've learned so much, and we are still working on future plans to be even more prepared. I will also be available for questions, and thank you for being here today. Aman?
Great, thank you very much, Michelle, for sharing. And sorry about the audio issues there. Thank you also to Dr. Sinha, to Kristi, and as well to you, Michelle, for sharing such rich information and examples about emergency response. I don't know about everybody else on the webinar, but I am still thinking about that table-sized slab of cake, Kristi, that maybe we can indulge in one day. I have the pleasure of serving as a volunteer on the Aga Khan Council for British Columbia, which is the social governance body for the Somali Muslim community here in BC. And one of the areas that I'm responsible for is emergency preparedness. Emergency preparedness has been a priority of the Aga Khan Council for British Columbia for years now. It's no secret that British Columbia is a very high risk region for earthquakes. And so we've focused a lot of time and attention on earthquake preparedness over the last, again, several years. And it includes communication to the members of our community. It includes education, as well as ensuring that we as an institution are in a state of readiness to support those in our community. Statistically speaking, again, the earthquake is the largest risk. We could have up to 3 earthquakes here in BC today, up to at a magnitude of 2.0 and above. And so we know that we have to be prepared. Any one of those can be the big one. And Dr. Sinha earlier mentioned, and I really liked how he put it, power outage to pandemic, and basically everything in between that we have to be prepared for. And just because we're living through a global pandemic, it doesn't mean that emergencies are on pause, and it doesn't mean disaster can't strike. And the greatest example of that is the heat dome that we experienced here in British Columbia over this past summer, amongst the fires that we've already spoken about. I know we have representation on this call or on this webinar from across Canada, and BC is often the butt of jokes when it comes to extreme weather, whether it's extreme heat or extreme cold. BC usually can't handle it, but the heat dome here in British Columbia was fatal. During the period in June when we had the heat dome, over the course of that weekend, there were 815 sudden deaths during that time, and 70% of those, or about 570, were attributed or were heat related, as declared by the coroner. Of those 570, 79% were those over the age of 65. And so, again, we know that, as Dr. Sinha has said, that our seniors are the most vulnerable in the event of an emergency. So I'm going to share a little bit about how we as a community, as the council, supported our seniors during that time to make sure that we were doing regular check-ins and providing the type of support that may be needed for our seniors to get through that heat dome. So, of course, because it was a weather alert, we had a couple of days notice that this was coming. And in anticipation, our leadership prepared a one-page information sheet with a script with some resources that included, what to do in the if you're feeling warm, what types of symptoms to be looking out for, how to dress appropriately, what to do in your homes, close the blinds, make sure the windows aren't open, so on and so forth, making sure that we had that type of information available for our volunteers. And we met with volunteers of our Care for the Elderly team, who themselves are seniors, but came forward as volunteers to support fellow seniors in this, seniors helping seniors model, again, to make sure that the seniors of the community would be okay during this time. Those volunteers then received a list of seniors to call, and we're doing wellness checks over the course of the weekend. They provided tips on staying cool, or making sure that they knew that, if those seniors don't have family or friends who are close by, that they could call that volunteer if they needed anything at all. And sometimes if we knew that the senior didn't sound okay or was perhaps isolated, we were making multiple calls a day. As an example for you, we called 2,000 seniors in our Smiley community to check up on them during the heat wave, or during the heat dome. Now, this isn't 2,000 phone calls. This is 2,000 seniors, many of whom were receiving 4, 5, 6 calls a day. And so again, this whole seniors helping seniors notion couldn't have felt more special, as difficult as the time it was. Seeing this happen was obviously such a wonderful experience for us to see and be a part of. We reminded seniors as well, now that you know that what to do during a heat wave, keep this in mind for next time. Make sure that you have a fan. Of course, at that time, fans and air conditioners were sold out, but make sure you have a fan, or make sure you're just taking notes on what to do. And we spoke also about some of the things that Dr. Sinha mentioned in terms of having supplies on hand, or anything in case you needed to evacuate or spend time at cooling centers, or perhaps stay with a family member where it would be safer for you. And when needed, if we didn't get a response on when we were calling, or if we felt like somebody didn't sound okay, we dispatched volunteers to go check up on them. Given the way that some of our, or given the geographical area in which some of our seniors live, we have many that live near the Smiley Center in Vancouver, which is located in Burnaby. And there are apartments that are 80 or 90% populated with the Smiley seniors, given the proximity to the Jamaat Khana, or the prayer space. And so what we've been able to do is, in each of those buildings, appoint what we call a captain, or a cluster captain. And that particular captain, in the event, be it an emergency or just even general checking up, helps us communicate with all the seniors in that building. So sometimes they're knocking on the doors to check up on them. During the heat dome, they were actually checking the thermostat, or if they didn't have the thermostat, we're going in with thermometers to see what the temperature was in the in the home, to make sure that they were safe. And this has really proven to be successful for us, because again, if we can't get a hold of anybody, or it's the middle of the night, and we really need to check up on a senior, these captains have been vital in us having a pulse on how that senior is doing. So again, I wanted to take just a few minutes to share that experience and how we've been able to respond on the ground. Of course, every chance we get, we thank our volunteers. So I'll take that chance here again, is to just acknowledge all of the volunteers that were involved in that, and all the other work that's done to keep our seniors safe and healthy. So with that, I know we've got a lot of great questions lined up that we'll be answering. And so I'll pass it back to Barb to moderate us through.
Great. Thanks very much, Aman. And thank you so much, Dr. Sinha and Kristi and Michelle, for those great presentations. And we do have a number of questions. There's a couple that I'm going to kind of lump together, and I think start with Dr. Sinha, but Kristi and Michelle may have some responses to add from their experience on the ground. And this relates to something that I was also really curious about when you mentioned it, Dr. Sinha, is the vulnerable persons list in your community. And so the questions relate to, how do you identify and list them? Who keeps the data? Who keeps the information updated? Are there people who don't want to be listed at all? Are there privacy considerations? And how can these issues be overcome? So we'll start with that one.
Yeah, no, it's a terrific question because we had a huge debates, you know, especially in our when we had our American Red Cross group working on this, because again we had folks from, you know, the CDC and folks in fire and emergency services, and the challenges is that there was really, you know, all these questions come up, right? You know, if you're going to create a registry, well, does everybody have to go on the registry? Is it voluntary? Is it not voluntary? How do you, you know, how do you maintain the data? How do you keep it accurate? All those sorts of things. What about privacy concerns? All these sorts of things. And so there really wasn't consensus because there could be problems. You create something, as soon as you create a list, it's out of date the next second. There wasn't necessary consensus from the group to say we must create a national registry. But what was recognized was in some jurisdictions, the power authority will actually have a list of people who are medically dependent on power, so that if they, and you can actually identify yourself in that way, so that when they're going around restoring power, for example, then they know to look for you. There might be a local municipality that actually has created a registry, or other organizations that have done so. So what we've just simply recommended that if this is a good idea, there might be a community where you like this idea. These are the parameters. It's voluntary. This is how we're going to do it, maintain it, everything else. But if there are existing registries that someone thinks would be valuable for them to be on, then we encourage people to think about that as another way that they can build in their emergency response plan. But again, it's one of those things where I think, again, you know, something like that has to be well thought out. It has to be well communicated, because you could have a registry and nobody knows about it. Well, that's not really going to help anybody either. So those are just some of the thoughts around it, but it's a real perceptive questions that people are asking about it. So it sounds like a good idea, but you know, it's not without its challenges as well.
Kristi or Michelle, do you have anything to add to that?
No, I would just also echo, you know, how hard it is to keep resource or registration lists accurate and up to date. But I think, you know, relying on our community service partners and making sure that they're in touch with their clients, that's our best defense right now, our way to do so.
Great, thanks. Okay, another question was around how can 30 days worth of supplies be stored in an apartment?
Yeah, so I mean, one thing that we're really lucky about in Canada is that in many places, you know, you can actually get I have patients who will get 6 months of medications dispensed to them in advance, or 3 months, or 2 months. And so it's the idea that if you have, for example, if you are filling up on medications, it's maybe trying to do it in such a way that you have, you're always 30 days ahead of what you actually need, for example. So it's thinking of it that way. Ironically, in the United States, that is actually not possible. People only get, you can only get medications, you know, for that upcoming 30-day period. But for example, you can't have medications for longer than that. So in Florida, they actually passed legislation that says that in the event of a hurricane or an emergent natural disaster, you can go to your pharmacy and demand a 30-day advance supply. But that's the only state where that's possible in a medical emergency. And the reason why we made this as a key recommendation was we were reading so many articles around Katrina and other things where someone might say, oh, come to our shelter or program, what medication you're on, we'll give you 5 days worth. And then they said, and then they come back 5 days later because their pharmacy had burnt down, and they need another 5 days. And of course, they're going to need another, you know, so in the end, what the consensus was is that when there's an emergency or disaster, there's so much going on. It often takes a lot of time for people with chronic conditions or that to get things sorted and to figure out a new system or have that infrastructure rebuilt or put in place. And hence, that's why the recommendation of a 30-day supply, whenever it's possible, be considered. Because again, if there's a forest fire that comes through town, burns down your pharmacy, it takes time to reconnect with your primary care provider, to get a new prescription, to find a new pharmacy, all those sorts of things you can imagine. That's why we say it's important to think about having a 30-day buffer.
I think you've answered partially one of the questions in the chat box, but I'll read the question because you may have something else to add. From Conrad, who says, Category 5 Hurricane Katrina in 2005, 1,800 deaths and 125 billion in damage. Category 4 Hurricane Ida in 2021, 82 deaths and 50 billion, the preliminary data. So what emergency preparedness planning actions were taken following the Katrina hurricane, a wake-up call that lessened the impact of Hurricane Ida?
Yeah, I mean, I'll look to my colleagues as well if they have any more information. So I don't know, for example, what were all the things that were done. I think some of the things that were done, structurally were kind of rebuilding levees and kind of reinforcing those, because that was one of the major reasons they had a significant amount of flooding that occurred before. But again, I think there was a lot of work that groups like the American Red Cross were doing to really promote these ideas of disaster and emergency preparedness, and trying to, as reconstruction was being done, to think about other provisions. So one of the things we learned about, or a handy tip that's actually been passed around in flood-prone zones, is to say that if you're a person who has, physical equipment, for example, like a walker or a cane, you may want to store an extra pair, for example, on the top floor of your house, because often what happens is that as the water rises during a flooding situation, people end up on the top floor, and their equipment is actually on the ground floor, for example, and it's the top floor and their roof is from where they're being evacuated from. So it's kind of actually, I never thought of that, but that kind of makes sense. So it's starting to think about what are the potential disasters that could happen here and what could be done. So I can't really speak to more specifics on what was done post that, but I certainly do know that Ida, as devastating as it was, particularly from the idea of loss of power for well over a week, was not necessarily as catastrophic as Katrina, where you had significant flooding and other things that happened. Hence why I think the death toll was less and the costs were less, but still not insignificant by any means.
Okay, thank you. A question for Michelle. What surprises did you encounter with the wildfire event?
A good surprise was the commitment that the community made to watch out for their neighbors. So during the whole alert and having a fire close by, neighbors checked in on neighbors made sure that someone else had a ride. So that was a really good surprise. And in that, we only ended up with 4 people that weren't taken care of. A not so good surprise I found was we were evacuated to many different communities. And while we were under one ESS task number, each host community had different resources for the same people. So some people had 3 days, some people had 7, some people had clothing, some people didn't. So I think for us moving forward, we want to be more involved in recommendations to ESS so that the whole community gets the same care no matter where they go. That would be the top 2 surprises for us.
But even I jump in, Michelle, and say, absolutely, right? You want to make sure there's a consistent response. But even it's that notion is that sometimes this is where we always debated a bit as a committee, saying that sometimes there needs to be a different response too, which is the idea that if you have, say, Indigenous clients, or people who have or there's certain ethnocultural perspectives, right? Is the community they might be heading to able to provide culturally appropriate and safe care? Is if you have older people with dementia, for example, we might know that this community doesn't really do well in terms of providing the accommodation or the support for those individuals. So it might even be an opportunity where that response, when folks were scattered across 7 communities, there may be an ability to say, this group should go here because this community can meet their needs. But you're absolutely right. I mean, the challenge are if people have equal needs, but they can be unequally met. Well, that doesn't really help anyone. So, so real subtleties here that your team certainly did focus on, and I am thinking about that cake as well.
Okay, we've got one more, hopefully a quick question. How can we get transportation organized for emergency?
Can I make a comment? So I think, like for us, I believe our municipality and our emergency operations committee had looked at that ahead of time. But having said that, you know, they're depending on the time of year, it might have been a school bus from Kamloops, but there were fires and they couldn't come through. We were lucky with tech that we had communications with that mine, that they were able to send buses. But most, I believe, municipalities will have some sort of a plan, an emergency evacuation plan, which would include some transportation, but also groups can kind of make up their own too, I think.
Great, thank you. We've only got 1 minute left, so I'm going to wind things up here. There are a couple of other comments and questions. One is about emphasizing the importance of older adults in our communities. And of course, I think we want to do that in all of our work and activities, but perhaps can be more intentional about it around emergency preparedness, response, and recovery because of the differences. And I think a lot of people in our communities may not be aware of both the physiological differences, some of the mobility challenges, all of the things that Dr. Sinha opened with. We've also been asked about whether people can share information on some of the tools that they've developed or stories or resources and make them available to other people on the webinar today. And absolutely, yes, I think we will set up a group on CORE Canada that's focused on emergency preparedness. And if you haven't joined CORE Canada, please do so, because then you can participate in groups, and we will have one dedicated to this topic where people can both ask questions, but also share stories and experiences and tools that they have found useful. A lot of the information, I think, about the vulnerable persons registries. There were more questions that have come up in the chat box around that. So clearly something that we need to look more closely at and get more information on. Aman has posted the link for CORE Canada in the chat box. There's also questions about, you know, language and cultural barriers. So I think that there will be information we can gather on that. But one of the last questions about how do you plan for disaster when information changes daily? And I could tell you a lot of stories about that, but I could also tell you that in my own community, where we are prone to potentially earthquakes, there have been forest fires. It's urban, but at the edge of the forest, only one road in, one road out, and very few emergency responders. We've actually done surveys and found that there was, one firefighter that lives in the whole municipality and 4 police. But we do have search and rescue folks, and we will be very reliant on each other and on being prepared in our neighborhoods and communities, because we can't expect that that emergency responders will get to us very quickly. So again, those questions about how do you store supplies. We know that in our community, there is a backup generator at our local community center. But again, it's getting the word out there. Lots of food for thought here, lots of great information. And we could talk a lot longer about this. And I think we will likely follow up with another webinar going forward. But in the meantime, we will post more information on CORE, including the recording and the slides from this session. The Closing the Gaps report is already on both CORE BC and CORE Canada. I believe it's also on CORE Alberta. And as I said, we'll post a group there so that all of you who do have examples and helpful tips and tools and resources can share them on CORE. So thank you again very much to our 4 fabulous presenters, very informative and lots that will help me both in my work in community engagement here at United Way, British Columbia, but also in the work that we plan to do in our own neighborhood with our local residents association, where this is a really top of the agenda of something to get started on this fall. So thank you, everyone, and continue to send questions to us or your examples at our email, barbara.m@uwbc.ca. Thanks again, everybody. And thanks to all of you who have attended and for the work that you are doing in your communities.